unfolded 2025. We from a peculiar case in renal transplant pleasure in wishing you a happy and prosperous new year again. This is our 43rd meet, and this is happened to be the first meet of 2025. And this meet is special because we have some good presentations, that's 3 presentations rather. And this year kicked off with this meeting. We have a good dynamic panelists, and we are proud to invite both the panelists. Dr. Santosh Varghese. This forum doesn't need much introduction about him. He's a well-renowned and from a renowned institute. He's a professor and head Department of Nephrology, CMC Vellore. And he had a lot of accolades, especially to mention as he's a director of HR in the CMC, and he's a treasurer of Indian Society of Nephrology and Indian ISOT. And he's also, he has a lot of credits to his name. And recently, the achievement of him, it can be evident from the recent award given by the Stanford University. That is, he's one among the top 2% world scientists. Actually, he's one of the 2% of world scientists as given by Stanford University recently. And we welcome you, sir, Dr. Santosh, to this program. And we hope to enjoy your feedback and your comments about the cases and all. And joining him is another well-renowned personality, Dr. Vel Aravind, who is my colleague, and we work in both the same city, the Trichy. And he's also well known as an interventional nephrologist, transplant nephrologist, and also a nephrosurgeon. Actually, is a very dynamic, have more than 2 decades of experience, especially in transplant intervention nephrology. He loves teaching, and the way of expression of his thoughts, even diagrammatically, and also by explanation by his words, jargons, and all, is amazing. And it's very amazing, and he has been inspiration to many of the younger nephrologists to see his aspiration and active inspiration drew from him for the field of work in nephrology and transplant is spellbounding. And he loves teaching, actually. And no doubt his inputs in these cases, especially in the second cases, will be worth noting. And we have 3 speakers to have for this presentation. First is Dr. Golicharan Nivash. He's a renal transplant fellow, postdoctoral renal transplant fellow from CMC Vellore. He's going to present a very rare case, actually. No doubt it comes from a premier institute, CMC Vellore. And he did his MBBS from Devaraj Woods Medical College, Kolar, and did his DM from Visakhapatnam, and he worked for 2 years in Narvi Hospital, Vellore, and presently renal transplant fellow. It's going to be the good cracker of case to start with. And second case, it is single disease entity with 2 different outcomes. It will be a very interesting one. First will be presented by Dr. Shakti Salokkumar, and he's also a colleague of mine. We both work in the same institute, the Kaveri Hospital, Trichy. And he's a young firebrand nephrologist. And we also know him from the peculiar case in his group, his active participation, and also being fondly called as a walking encyclopedia or Wikipedia of a transplant. He's very passionate of renal transplant. He had many accolades to his credit, and reason being the Tankers Young Investigator Award for developing an ISOT SWAP software that reflects his passion towards transplant and nephrology. And this another presenter is a well-known presenter, that is Dr. Vilas Naik. He's a director and concerned nephrology of Diamond Super Hospital, and he's a very aggressive and an expressive nephrologist and transplant physician. He's also an active member of peculiar case series groups. He used to post his answers, crisp answers. He's known for his crisp, sharp responses. And we all welcome, we are once again pleasure in welcoming you all, the panelists and speakers for this program. And I invite Dr. Golicharan to start his presentation.
Good evening, everyone. Thank you, sir, for a great introduction. And I would like to thank both Rajarajan sir as well as Santosh sir. And coming to the case, this is an unknown native kidney disease, but not
Can you
rare.
make it full screen, Charan? Can you make it full screen?
Yeah. Is it full screen, sir? No?
Yeah, please go ahead.
Yeah. So this patient came to CMC Vellore for a renal transplant in April 2012, being mother as a donor. Name his name age 38-year-old male. He's from Salem, Tamil Nadu, and a computer engineer being occupation. And I would like to date back the history to 2001, when he is 17 years of age, when he developed this unprovoked seizure, which were requiring anticonvulsants, and he continued to have these seizures for over the next 5 years, and he was on multiple anticonvulsants. And in 2009, he had a routine visit to local hospital where he's found to have hypertension, and he's having proteinuria or urine test. Doesn't have much of blood leak in urine, and he was having non-biopsiable kidney on ultrasound examination, and he could remember the creatinine to be 3 at that point of time in 2009, and he was started on losartan, which he was irregular on. And by December 2011, he was started on hemodialysis via right IJV catheter in outside private hospital in view of uremic symptoms. And at the time, his creatinine was 12. So by Jan 2012, at the age of he was 29 years of age, when he came to CMC Vellore for transplant with mother as a voluntary kidney donor. At the time of presentation, then he was on thrice weekly maintenance hemodialysis for the last 2 months via this right IJV catheter, and he had history of nocturia, swelling in both the legs, vital edema, along with difficulty in hearing for the last 3 months. And later on evaluation, it was found that difficulty in hearing, he was having sensorineural deafness on left side, and he doesn't have any chest pain or hematuria or joint pains, rashes, or abdominal pain or constipation, and he doesn't remember having any blood transfusion. And at the time, his residual urine output is about 200 ml per day. So coming to family history, his father died young at the age of 25 years. And other than that, there is no significant family history. Mother's side family is also fine. No history of any kidney ailments for them. And on general examination, at that time, he was having pedal edema, and he was having pallor. He doesn't have any rash. And for the transplant, he got clearance from neurology, dental, as well as psychiatry, and he was proceeded for transplant. At that time, these are his baseline characteristics, where he was having mild anemia, and viral screen was negative, and proteinuria is significant. UP by UC, you can see it is 7.04, and with mildly high PTH, and he was having subclinical hypothyroidism. Other than that, most of them are normal. ECG and echo were also normal. His blood group was O positive. These are his ultrasound findings at that time, where he's having borderline kidneys with which are completely echogenic, and there is complete loss of CMD. So biopsy could not be possible then. After doing CDC crossmatch and HLA DSA Luminax, mother was taken as a donor after doing all the basic investigations, and both are ABO compatible. Mother was also O positive, and both of them had haplomatch. And NKD, after thorough investigation, NKD was taken in as unknown, and he was proceeded for kidney transplant on April of 2012. Induction Basiliximab was used as induction agent, and during the surgery, he had some prolonged warm ischemia as well as cold ischemia time. Some two or three times he was reanastomosed, and finally, so after there is some prolonged cold ischemia time. So post transplant, immediate post transplant, he had delayed graft function, and he received 3 sessions of hemodialysis during first 10 days, and he was started on triple immunosuppression. Later, his creatinine stabilized, and he was discharged, and he was nadir creatinine has reached to 1.7 on day 20, and he was discharged with a creatinine of 1.9. During the hospital stay initially, two biopsies were done. First biopsy was from intraoperative on April 25th. Both of them were showing acute tubular necrosis. IF was negative and C4T was negative. So they were taken as no signs of rejection were there. DSAs were class 1 and class 2 were negative. TMA parameters were also checked, which were negative. So over the next 2 months, the creatinine continued to be stable between 1.7 to 2, but never creatinine went below 1.7. And his TAC and MMF doses were modified as per therapeutic level. And by August 2012, that is 4 months post transplant, he developed this resistant hypertension, needing 3 to 4 antihypertensives. Initial Doppler showed elevated PSV, for which angiogram was done with balloon angioplasty. Post procedure, antihypertensive medications were tapered, and he was only requiring one antihypertensive post that procedure. But during that time, he developed some amount of graft dysfunction, for which we have done a repeat biopsy, where we could find again some acute ATN changes without any rejection. Again, DSA class 1 and class 2 were negative, and it was thought that it is because of contrast induced. And at the time, EM doesn't have any glomeruli. During the same period, he got this genital herpes, for which it is treated with acyclovir, and his repeat renal Doppler was also normal again. Going to By November 2012, that is 1.5 year post transplant, he underwent circumcision for melanoprosthitis, and a biopsy from that propose was showing this telangiectasia. Otherwise, there are no specific lesions. That is the first clue, I guess. So going to August 2013, 1 year, 4 months post transplant, he had this right thumb lesion, which was biopsied, which showed squamous cell carcinoma in situ from the right thumb. He was treated with cryotherapy and radiotherapy, and amputation was done of right thumb at proximal phalangeal level. And the plan was actually to change to mTOR inhibitor in view of malignancy potential and other things, but it is deferred finally because of proteinuria. At the time, proteinuria was around 800 to 900 milligrams. And by November 2013, he was diagnosed to have PTDM. He was started on OHAS. And in July 2015, that is 3 years post-transplant, he has got CMV viral load, which was positive, treated with Valgan. But he continued to have stable creatinine between 1.7 to 2.1 in between over the last 3 years, but never creatinine went below 1.7. And he has this suicidal tendency similar to father. So psychiatric opinion was taken, and he was managed. And by June 2013, January 2016, you could see there is proteinuria continued to rise. Initially, the proteinuria was 300, 500, and 800. Now it went to 2.9 to 3.5 grams, for which he was rebiopsied again in view of significant proteinuria, but his relatively graft function was stable. During this, we found that on light microscopy, there are foamy vacuolization of podocytes, and there are FSGS changes with some acute tubular necrotic changes. IF was showing segmental trapping of IgM and C3, and EM was diagnostic. It is showing zebra body, myeloid inclusions in both podocytes as well as distal tubular epithelium, which are consistent with Fabry disease. So this is when we got a diagnosis of Fabry, biopsy-proven Fabry, and this is a representative slide showing the GB3 inclusions, which are seen as vacuolizations in podocytes as well as other cells, mesangial cells, endothelial cells, and parietal epithelial cells. These are the inclusion bodies on toluidine blue stain. And these are the EM findings. If you see on on the side of podocyte side, there is this lamellar inclusions, which are zebra bodies, which we call as zebra bodies. Even these lamellar inclusions are even present on the mesangium. Some lamellar inclusions are present on the endothelial cells, even on the electron microscopy. So this is so after getting the finances from ESI, because the wife had ESI, so we got the finances, and by 2018 we found this. We send testing for enzyme analysis, found to have alpha galactosidase enzyme to be low. It is 8% of the mean value. usually mean percent of the mean value, definitely less, but not in correlation with the classic Fabry's, where the levels will be less than 3. But it is low, definitely. Less than 30 is always low. So then we confirmed with the GLA gene testing. Clinical exome analysis was done, where pathogenic variant was confirmed with this analysis. So then the diagnosis was made. Over the next 2 years, the renal function dysfunction progressed, and he was started on peritoneal dialysis by May 2017. In October 2018, finally, with the finances ready, on dialysis, he received 6 infusions of galsidase beta, that is injection Fabrazime. Dose is around 1 mg per kg. And after taking these 6 injections, he felt better. By April 2019, he continued to be on peritoneal dialysis. Unfortunately, in August 2021, he expired secondary to acute CVA. He had a massive intracranial hemorrhage involving pontine region and along with aspiration pneumonia. So he expired in August 2021. So this is summary. To summarize, symptoms started in 2001 when he had seizures at home, where he was on multiple antihypertensives, anticonvulsants. In 2009, he found to have renal dysfunction with proteinuria, and he went on to dialysis in 2011. Got a graft kidney in 2012 April, and found to have squamous cell carcinoma of right thumb in 2013. As per kidney biopsy, found to have Fabry's disease, done for this significant proteinuria. And by 2018, the graft failed, and he was started again on dialysis. And in 2019, he received total of 6 infusions of agalsidase beta, that is Fabrazime. In 2021, he is expired. So coming to this Fabry, I want to discuss some few points. That is it rare or undiagnosed? When to suspect Fabry? How to diagnose? When to start the treatment? Is there any role of enzyme replacement therapy in ESKD patients? And whether renal outcomes with enzyme replacement therapy on transplant? What are the renal outcomes in enzyme replacement therapy? Coming to we all know that Fabry is an X-linked disorder. Inborn error of it's an inborn error of in glycosphingolipid metabolic pathway because of deficiency of alpha galactosidase A, which is present on GLA gene on X chromosome, and because of the reduction or absence of this enzyme, there will be accumulation of this GB3, that is globotriacyl ceramide, in a wide variety of places everywhere, most of the organs. So all the manifestations of disease are mostly because of this accumulation of this GB3. So is it rare or undiagnosed? Actually, prevalence of classic Fabry, that is in case of males with enzyme activity less than 3, it is usually 1 is to 10,000 to 1 is to 1 lakh, but it is mostly underestimated. If you see the neonatal screening, there some places they are doing this neonatal screening where the incidence is approximately 1 is to 4,000. They are doing for this 143T gene where the incidence was found to be very high. So, and most of the problem with Fabry is the most of the manifestations are also non-specific. If not for classic, there are two types actually, classic as well as non-classic. In case of classic, are commonly seen in case of males with low enzyme activity, that is less than 3%. In non-classic variant, they may have different presentation. Some will have only organ-specific presentations. Some patient may have only kidney problem. And in Taiwan, we see some people having only cardiac manifestations. Other than cardiac, there is nothing other than that. So diagnosis is often not considered. That is the problem because of rarity. And initially, the wrong diagnosis is made. And most of the time, it is not the pediatrician who diagnoses. Though the patient manifests early, that is in the first or second decade, it is not the pediatrician who diagnoses because of slowly the other symptoms also evolve, and the other people slowly the other clinicians are the one who will diagnose eventually. As per Fabry outcome survey, which were done in a number of countries, there we could see there is mean delay from 13 to 16 years for diagnosis of Fabry. So when to suspect Fabry? One is obvious, that is if family history is there, definitely we have to suspect because it's an X-linked. So mother to a daughter or mother to son transmission is known. And coming to clinical manifestations, if there is any intermittent episodes of this burning pain of extremities, example, these young children, especially 5 to 10-year-old male child, if you see them, they are not playing with their peers. Most of the time, they will be because of this exercise and stress, or because of fevers also, they will get a lot of pains in the hand and feet. So they will not be playing with their peers. They will be moving away. Initially, if they take them to the pediatrician will be saying that it's growing pains, it's okay, not a problem. So but slowly other manifestations come up, then they are likely to get this diagnosis. And other when to suspect is when there is this angiokeratomas, that is cutaneous vascular lesions. These are bright red lesions which are actually present on abdomen as well as thighs, which are non-blanchable. This is classic. So dermatologists are the one who really picks up this fabris. And other features, hypohidrosis because of reduced perspiration, because these deposits also get deposited in the sweat glands. And there are this corneal and lenticular opacities, there are cataract, there is this corneal dilatation of vessels will be seen, and the spoke ray appearance on cornea will be seen. And even the retina also has this dilated vessels, blood vessels, which are seen. And some irritating symptom is this abdominal pain, nausea, diarrhea. They will have diarrhea. Unfortunately, if they go to some where they will be getting diarrhea immediately, so it is very difficult for the patient. There are a lot of very depressing stories regarding this diarrhea. People going somewhere to some buy some groceries, there they are getting this sudden onset diarrhea. And there is so another place where we have to suspect is left ventricular hypertrophy of unknown etiology. The person will not have any hypertension, but he will be having significant LVH. We had one case in CMC where he was having LVH, but he was not a hypertensive. So when on further evaluation we found that he had this Fabry's disease. He was found to have Fabry disease. Especially when we do a cardiac MRI, there will be this myocardial fibrosis which we see in posterolateral part. In case of females who are not classical case of Fabry, they also will have main finding of on cardiac MRI only. You will know that there is myocardial fibrosis. That is how we make that the patient is suffering from Fabry. And other problem is arrhythmias, most commonly atrial fibrillation. And whenever somebody had stroke of unknown etiology on at any age, and CKD of unknown etiology, and when somebody is having renal pelvic cysts, also we have to suspect Fabry. So how to diagnose it is it is based on mainly sex. If in case of males less than 3%, diagnose is done and dusted. If it is below between 3 to 35, we have to go for DNA analysis. In case of females, we have to go for DNA analysis. Once we performed GLA gene pathogenic variant is there we can diagnose. If pathogenic variant is not found, there is a variant of unknown significance. Then if we can perform a biopsy of organs specificity, if there is kidneys involved, then with that biopsy we can diagnose Fabry's. If they we can find any if there is any evidence of intracellular GB3 inclusions also, then also we can diagnose Fabry. This is how we have to diagnose. And when to start the treatment. In classical cases, in severe cases, we have to start once the diagnosis is made. In case of other patients who are having a family history of Fabry, on appearance of first symptom, mostly first symptom will be acroparesthesias, that is painful neurological pain in the foot as well as this hands. This is the first symptom when we have to start the treatment. In case of renal perspective, proteinuria is the one which we see early in second decade usually. So adolescent age group is the one where we have to start treatment whenever the proteinuria is high. There are two treatments in case of Fabry. One is fabric specific therapy, and another is non-fabric specific therapy. Non-fabric specific therapy is just like treating the complications. If the patient has CKD, treat CKD. If the patient has neural issues, treat with the pregabalin and other things. And these are adjuvant therapies we know. And Fabry specific therapy is important. We have two. One is enzyme replacement therapy, another is chaperone therapy. In case of enzyme replacement therapy, we have this egalsidase. Two are there right now, which are US FDA, EMA approved and US FDA approved. One is egalsidase beta, that is Fabrazyme, and the dose is 1 mg per kg IV infusion. Every 15 days we will give usually. And the other one is egalsidase alpha, where the dose is 20% of the needed dose, whatever it. And it is also every 2 weeks. And the third one is this chaperone therapy, where here we will not treat everyone with chaperone. That is not will not treat everyone with megalostat. Actually, megalostat is the chemical molecule which attaches to the protein, and it protein, that is agalsidase enzyme. It will attach to the protein and it prevents its misfolding, and it will show the right direction, and thereby increasing the enzyme activity. Thereby, it will increase the activity. We can't start megalstat for each and every person. We have to know which person we have to start. We have to know which person we have to start. That is, there is this study where there is this study. GLA specific mutations are there which are amenable for therapy. So only 35 to 50% of GLA mutations are amenable for this megalostat therapy. Other 50% it is usually not useful, and so we have to know exactly all the patients. We can't just start this megalostat. Only these few cases we have to know. First, GLA mutation, we have to search the database, and on the database, if they are having positive evidence, then only we can start this megalostat. And unfortunately, this can't be used before in patients with EGFR less than 30. And uh, but there are two big studies. Facets, one is Facets trial and other is Attract trial, where they have found that megalostat is having good reduction in case of diarrhea symptoms, good reduction in proteinuria, and also reduction in LV mass. And coming to the Fabrazyme cost is around 2.8 lakhs right now, and this megalostat is Galafold. Right now, Intus from April 2024, they have got the approval for producing this generic variant of this megalostat. Still, it is not released. I think the cost may come down after this. The dose is usually 123 mg alternate day. So, is it enzyme replacement therapy in ESKD necessary? Is it safe? Yes, definitely. And why is it necessary? Not for us as a nephrologist, we already know the kidney is gone, but for especially to reduce the cardiovascular risk, it is very important to start them on therapy. And if there are some studies where the prevalence of Fabry disease is very high on dialysis, it is approximately 0.87%. Coming to graft and patient outcomes after kidney transplant, this is a big meta-analysis which was there on based on kidney transplant, where they have found allograft as well as patient outcomes in patients of Fabry disease are comparable to other kidney diseases. Even in European Renal Registry and US Renal Data System also shows that there is a graft survival as well as patient survival is as good as other non-Fabry disease. And initially they found that they were exploring the idea that transplant may be a solution for this increasing this enzyme activity. Because of this graft may produce some amount of enzyme initially transiently, but afterwards this whatever enzyme activity is produced transiently will eventually come down. So eventually they will need this enzyme replacement therapy even. And if you see the recurrence rate in Fabry disease usually is 11% from duration of from 3 to 11 years. So unfortunately there are no studies as of now on megalostat. So current evidence shows that short, long-term, and patient graft function outcomes are not inferior to those of ESRD of non-Fabry. Here we actually got the case after. I mean, we got Fabry disease diagnosis after transplant. We tried to see whether there are any other history like that. So here we found a Fabry disease in case of they found Fabry disease after screening kidney transplant patient, where the NKD was unknown in Italy, and they found GLA mutation was present in 2.6%, which is very high actually, and out of which 2 cases were classic Fabry, out of which 1 case on enzyme replacement therapy done well, and his proteinuria has maintained at the same level and creatinine was stable. The other case eventually went on to dialysis. So other people also shows this unrecognized GLA mutations incidence is very high. So actually the incidence of unrecognized FT is very higher than what diagnosed. So it is not rare, definitely. And we have to have money and other things also to diagnose this Fabry disease. So, yeah. Thank you.
Thank you, Dr. Golicharan, for a neat, simple presentation. And we've already half an hour. So quickly, we just ask Dr. Santosh, who must be involved in this case also. Your comments, please, sir.
Yeah. So we've had, this is the second patient, another patient whom we was referring to. Patient had a unexplained HOCM on pre-transplant screening, but
Karan,
otherwise he was all
please
right.
unshare the slides so we can see the photo. Raj, ask him to unshare the slides.
Yeah.
Fine, yeah, this one.
So we had another patient we had who had HOCM on evaluation, but it was not very severe. So we proceeded for transplant. He was not hypotensive or anything. And we after transplant, kidney biopsy showed Fabry. So this is not rare. Our message is that this disease is not rare. Unfortunately, we had another patient who one of my colleagues presented in another meeting in which the patient had a scrotal lesion, but it was unnoticed. He had not brought to anyone's attention, and the genetic analysis showed a Fabry. So Fabry is not unknown in our patients, and only if you have a high index of suspicion. Here, I think the seizures may have been a clue, but so many of our patients have seizures, and we don't bother much about it. I think it's a good idea for us to keep Fabry's in the back of our mind and see and some sources of replacement therapy provision is there. Earlier, the company Genzyme was giving it on compassionate grounds to people who are not affording, but now last several years they're giving it only to those who have insurance or government or ESI. So it took a while for this patient to get. So message is that it's not a rare condition. Look out for it. That's what we want to say. And I thank Charan for a fantastic presentation. And my colleague Jitu was also very involved in helping with this presentation today.
Thank you, sir. Thank you for this. Actually, I have two questions to there. That's simple two questions. So, when the patient having an organ-specific Fabry, that is kidney only involvement, on dialysis, is it the ERT, that is enzyme replacement therapy, is warranted for that patients also?
Yes, sir. It is very much warranted, sir, especially for cardiac outcome. And when they're having cardiac outcomes, when somebody is having left ventricular hypertrophy, it is shown in studies that the cardiac outcomes were better when the patients are on dialysis. Even the patients are on dialysis. So
they
not for kidney per se, but it is for cardiac, other organs.
So it has to be continued for their lifelong, that replacement.
Yes, lifelong they have to continue.
Fine. Next, another one, after transplant, Fabry's disease transplant, it has to be continued for lifelong. Your outcome, you have shown the outcome of Fabry's disease with non-Fabry transplant outcome. It is with the ERT, no?
Yes,
they have to be on ERT.
It is with ERT.
Okay. They have to be continued for life.
Better. Yes, sir. Only initially when this enzyme, initially this graft will produce some graft cells will produce some amount of enzyme, but it will not last long actually. So definitely we have to start ERT, and for all the other organs also we have to start. Another thing is for duration also, they have divided into two eras. Era before 2001, when this FDA has not approved this ERT, and era after 2001. And when they compared this both, definitely the graft outcomes were better after 2001, when they started to add this enzyme replacement therapy. And the problem with enzyme replacement therapy is they will have this antibodies most of the time. So there will be development of these antibodies to the enzyme. Because of our immunosuppression, they were doing a lot better on transplant than non-transplant patients, because already the patient is on immunosuppression and they are not developing this antibodies faster when compared to non-transplant patients. So they have found tolerance of this enzyme replacement therapy far better in case of transplant patient than non-transplant patient.
But they cannot do fair with the money, no? It's 2.8 lakhs per vial. It has to be given every 2 weeks for lifelong. I don't think so. Our patient can afford all these things at all. And thanks for if there are no further questions. And Dr. Vail, sir, your comments, please.
I learned quite a few from Charan. It's a very nice presentation. So it's eye opener. As Santosh said, it's I think we have to keep in mind. That's all. It's a good presentation. Enjoyed.
That slide of that when to suspect Fabry is very important to us. Actually, we can
Ah, yeah.
have a thing. Many LVH, undiagnosed LVH, we need to screen for that. So, if no further questions, and I thank Dr. Charan for the excellent presentation to bringing in a very rare case to this podium. And let we start the second presentation, second case series. That is, Dr. Shakti can start his presentation.
Sakti?
Good evening, everyone. Can you see the slides?
Yeah, yeah.
Yes, sir.
So, good evening, all. Thanks to Dr. Rajarajan sir and Dr. Vail sir for the opportunity. Let me start. So, this case is going to be a two-parter. Chapter 1, the cadaver catastrophe and the Trident Jugaad. 37-year-old female presented with history of dialysis for the past 3 years. Native disease unknown. She presented to me for renal transplant, cadaver transplant. History started in 2019 January. During her second trimester of her second pregnancy, which was natural conception, she was diagnosed to be having proteinuria, hypertension, renal dysfunction with a creatinine of 2 mg per deciliter. Other reports were normal. She had contracted kidneys on ultrasound, underwent medical termination of pregnancy, and deferred immediate therapy. Past history, her first pregnancy was normal, natural conception, and no hypertension. Documents and reports were unavailable. No family history of preeclampsia or renal disease. Her brother had Marfan's. No previous history of any other comorbidities. 2021 February to 2023, the history is as follows. In 2021, she was started on dialysis, had multiple access failures, recently underwent AV graft placement. She is thin, emaciated, malnourished, continued to have multiple episodes of hypotension during dialysis. She was worked up for transplant. Single antigen was done, which showed minimal MFI of less than 1000 for multiple MFIs. Complement levels were normal. SLE workup was normal. Iliac Doppler was normal, and she was deemed fit surgically. On 2023, September 13th, she got an offer. The 30-year-old brain dead donor was offered to her. Cause of death, RTA, with no prior comorbidities. Creatinine was 0.78. They accepted the offer. Allocation was done with CDC cross-match. Retrieval was done by the donor hospital team. Donor had 3 arteries and 3 veins, which converged to form a single vein. Unfortunately, during the retrieval, all 3 arteries were transected close to the renal hilum. The confluence vein was also transected, resulting in 3 veins of short lengths. What to do now? Discard the graft. The recipient had limited options. She already had access failures, hypotensive episodes during dialysis. So this offer cannot be refused. Jugaad is a specific Indian term where we Indians utilize certain specific limitations to achieve certain results. What we did on the day was a vascular Jugaad. Over to Dr. Vail, sir. Sir, you can share, sir.
Yeah, sir, you're muted.
Fine.
Yeah.
Something's interfering.
Yeah, sir.
Something. Yes. 1 second. Okay. So she's a real surgical challenge. It's not moving, man. Sorry.
You can close and come back, sir. You can just close it.
Sorry,
Yeah.
it's not moving at all. 2 seconds, okay.
Sir, I have the presentation, sir. Can I share from my side?
Right, it's coming. Okay, it's not. See, generally, I just go with a few minutes of retrieval technique one should adapt to during the once the liver everything has been out, heart, lung, and everything. Then we are left over with some kind of few staffs inside and some pressing necessity from the surrounding that the surgery has to be finished completely or the funeral rites to be undertaken. So with that pressure, when you go inside and sometimes we may make mistakes in a hurry. So that's what happened. But the routine protocol is when you see both kidneys lying on either side, we don't know which side is having how many arteries on either side. So generally what we do, we take because already aorta is cannulated, we remove that cannula, we make a longitudinal slit, so because most of the time, I mean, generally, both renal arteries are arising from the sideways, just make a longitudinal slit. That will give you idea that how many arteries through that hole, you can identify how many arteries are there between the two, approximate length between two kidneys. This is what we should routinely people will do. And likewise, the left renal vein you can cut, as shown in the figure here. We have to cut the upper IVC and lower IVC in the end block. We'll give it to the team, whichever the team accepts, right kidney, left kidney. This is the way the routine procedure is done. So this is what it shows. Once you slit open and you can see the one artery either side, and renal vein is cut, and right renal vein has got a upper small IVC cuff and lower portion little cuff. Because why this they are giving this kind of IVC length? Because we can make it, we can tubularize and make it a little bigger if a patient is obese, or you can cut close to the IVC joining the renal vein. That's depending on surgical team and necessity of the recipient's room space for accommodation. So this is the thing. Whenever you have a renal artery, you have the main renal artery and extra renal artery. The extra renal artery will be either it be accessory hilar artery or polar artery. The polar artery can be aberrant or normal. When you call aberrant, the lower polar artery will cross over the ureter, which may cause hydronephrosis. This is one of sometimes if you see in a young patient with hydronephrosis with no cause ruled out, and this is aberrant lower polar artery to be ruled out. So generally, any polar artery will traverse below the ureter. You call it as aberrant because the course is unusual. So this is what we call it as upper and lower polar artery, hilar artery, and accessory hilar artery, either above or below. And generally, the thing is, the hilar arteries will enter into the hilum through the pad of fat, along with renal artery, and the ureter will be visible in the middle of the kidney. And the polar artery will usually pierce the capsule. This is where we identify. So this is the general things about things. So here what we got is these closely cut renal 3 arteries. I think probably would have been all in common stem. We don't know the real scenario on the donor side. When we received, it was 2-3 different arteries, at least for 1.5 centimeter distance apart. So the central artery was little. We were clueless actually. Initially, we thought of going with 2 internal artery iliac artery divisions and 1 to the external iliac artery, and for the recipient side, deep inferior epigastric was not adequate, and its quality of that vessel was not good. So what we had a choice was, we took the aortic wall, which was dispatched along with the graft. So we made it slit, and we made like small like wall, like as shown in the figure. And we made artificial openings on that aortic wall using aortic punch. The central one, there was some little stump was there. We utilized for the central anastomosis. This is what the we called as artificial Carrel patch. Instead of all in one, we made anastomosis through that artificially made openings, and we cautiously we just made sutured along the whole opening of the aortic wall. Likewise, there is one bit was available along with the graft renal vein, iliac vein. We took that as an extension graft. This is what we did for that patient. This is the sudden thing which appeared in our mind. Otherwise, this kidney would have been gone to trash bin. So this is what after this thing, and this is a 3-dimensional view. I'll go straight away there. After anastomosis, you can see the artificial Carrel patch was we preferred external iliac artery. We made a very long, almost 2.5 to 3 centimeters incision along the external iliac artery, and we put the aortic artificially made a Carrel patch and started anastomosing. Likewise, we did took a patch from the iliac vein. We anastomosed to the hilar vein, which is very close, the renal vein graft, which is very close to the hilum. We extended with that graft, and this is what final look is all about. I'll show the video. So this, for the paucity of time, just pass this 2 videos, because there are 3 renal vein. So we can listen at least. It is good at least.
There are three renal veins and must have confluenced to become one renal vein. And accidentally it was cut into three pieces. So we took one venous segment from the cadaver organ, and we anastomosed two here and one here, and we made it a common stem.
So this is what this thing. Fine, this is a technical aspect of the anastomosis, and we just.
There are three branches. There's a lower pole artery. The two hilar arteries. One is the main hilar artery, and another accessory hilar artery. Third one, we had a patch from the deceased donor. This aortic thing. We made an artificial caral patch, and we are anastomosing to the external iliac artery.
So this is a final look.
Deceased donor had three arteries. It was inadvertently all three were cut near the hilum, which when we received, each had a 2.5 centimeter, this is 2 centimeter, and this is 2.5 centimeter. We took aortic one portion of the one wall, and we made it artificial caral patch. One we anastomosed here, the another one we made a hole and anastomosed the distal one. This middle axillary hilar is the main hilar. We made a hole on the aortic wall, and we.
So the final look is first artery, middle artery, third artery, and this is the vein, first and second, third vein. The outcome was really astonishing, and we were really happy about the outcome. And so this was the, I think this Sakti will show. This is the 1 year later. This was the thing. I think we'll show this. Over to you, Sakti. Sakti. Sakti.
Please share your slides. Okay. You continue your presentation.
Yes, sir. So I'll move to the second part of the presentation. Chapter 2, the LDH conundrum and the usual suspects. Induction was 4 mg per kilogram ATLG. She received pulse steroids. MF was started on POD1. TAC was withheld in view of delayed graft function. She was extubated on POD1. As expected, she was anuric. She underwent a session of hemodialysis. This was her reports, except for LDH, rest were normal. I wouldn't say normal, but expected for a POD1 patient. LDH was 341. What is the use of LDH monitoring in cadaver transplants? LDH catalyzes the reversible conversion of pyruvate to lactate. It's present in almost all the tissues. Predominantly, it is an intracellular enzyme. It's a non-specific marker of tissue damage and anaerobic metabolism. The normal value is 240 to 480. A study by Touche and others showed that POD1 LDH correlated with the delayed graft function and a prognostic marker for delayed graft function. A study by Aldrubin and others showed that 25% LDH is higher in hemodialysis patient compared to normal population. So how would be the trend of LDH post-transplant? This is how the LDH would be in uncompleted recovery post-cadaver transplant. So it will be, there will be an immediate rise followed by a plateauing around a range of 300. In a case of delayed graft function, the value rises, peaks, and then it gradually falls down. In a case of delayed graft function along with acute rejection, there will be a steep peak followed by a fall and then a rise during recovery. Period 2, I got a call from one of my staff telling that the LDH value was unusually high. It was 1971. I did not believe, so I did it myself again. Sent to the lab. The repeat sample was 2076. I was shocked. The peripheral smear was done at 12 p.m. It showed schistocytes and the impression was anemia of hemolysis. Another shock. So who are the usual suspects in such cases? Renal tubular TMA, systemic TMA, rejection, renal infarction, and hemolysis. How to differentiate these 5 in a case of post-transplant? Schistocytes will be rare in case of renal infarction. Thrombocytopenia will be severe in a case of systemic TMA, but it will be absent with hemolysis. C3, C4 will be low in systemic TMA and normal in other cases. Haptoglobin will be low or absent in a case of systemic TMA or hemolysis. Graft Doppler was done at bedside immediately. As you can see, the flow was excellent. Normal artery and renal flow. RI was 0.6. PA was 0.9. Graft was not swollen. So renal infarction was unlikely. C3, C4 was normal. CPK total was normal. Haptoglobin normal. LFT normal. And reticulocyte count, absolute reticulocyte count was normal. Systemic TMA and hemolysis ruled out. We are left with renal TMA, rejection. What are the way to identify that? Renal biopsy. On POD3, LDH was 2132. I did a biopsy, took one core from upper pole for LM, another core from upper pole middle pole junction. For IF, took a core from upper pole middle pole junction. The core appeared somewhat normal. I was waiting for the biopsy report. On POD4, LDH was 1800. I got a call from the pathologist. He said I had a bad news. And just like that, all hell broke loose. And this was the biopsy report. Diffuse cardiac necrosis with fibrin thrombi in all 25 glomeruli and 25 arterioles. Band score was G1. So what now? Plasmapheresis, eculizumab, unlikely options. As you can see, it was diffuse cardiac necrosis. So there is not much graft to save. Graft nephrim was a viable option. So I counseled the attenders and they informed me not to tell the patient. So we were waiting on contemplating on what to do next. POD5 at 7 a.m. I got a call from the staff telling that patients are having output 30 ml, 35 ml, 40 ml, 50 ml. Gradually it was increasing. I gave a dose of 80 milligram furosemide at 8 a.m. The output improved to 80 ml and 85 ml at 9 a.m. 10 a.m. So the graft was still surviving. Could it be an HLA AVMR? There was no sensitizing history and all MFI was less than 1000. Could it be ischemic reperfusion injury? Possible, but the cold ischemic time was less than 6 hours. Could it be TMA? Bit unlikely. The natural history was not suggestive of TMA. I had a lot of confusion. Then I got an epiphany. The initial suspicion was renal infarction. That's why we did Doppler. If you look at the vessel orientation, it is not parallel as what I thought initially. If you could see this video, which was played by Vale sir just before, you could see the middle artery was going behind. It was not exactly parallel, but a 30 to 40 degree tilted. So there's a concept called as tilting in focus, where you shift the probe around 30 degree to 45 degree angle to look at a 3D-dimensional. Kidney is 3D organ. So obviously tilting has to be done. So this is what I did immediately. As you can see, the upper pole flow was normal. Then the lower pole flow was normal. And then tilted, looked at the middle pole. There you go. This is an artifact. In a place where supposed to have flow, you are having artifact. So I did a renal angiogram. As you can see, upper pole artery and the lower pole artery are supplying the graft, but not the mid pole artery. You can see the annotation. The middle pole artery is occluded. And you can also see the artificial chiral patch made an anastomose to the external iliac artery. A 3D reconstruction showing the same thing. So possible explanations. Why did we get schistocytes? High shear stress causing mechanical fragmentation. And thrombocytopenia could be because of downstream microvascular ischemia causing secondary thrombosis and consumptive thrombocytopenia. Anemia because of microvascular hemolysis. Why did we have G1? Mild glomerulitis because of neutrophilic infiltration, secondary ischemia and necrosis. It is often focal and seen at necrotic areas of the cortex and medulla. So the next question would be, why did we have necrosis in the upper pole sample? You could remember I took 3 poles, right? And all 25 glomeruli was necrosis. As you can see in the 3D reconstruction, there is a small branch from the upper pole which is giving to the middle pole, and vice versa. A part of the upper pole is being supplied by the middle pole artery. You could see in this 3D reconstruction, the lateralmost part is supplied by the middle polar artery, while the middle most part is supplied by the upper polar artery. Further cross, tacrolimus was started on POD5. I aimed at a lower than normal target level. Started on heparin TID and was discharged with NOAC. LDH started dropping. Creatinine normalized almost 2.5 1 week later. Platelets picked up to 2.5 lakhs. Urine RBC is present. Output gradually improved. 1 month later, LDH dropped 315. Creatinine was 1. Hemoglobin improved 8.8. Platelets normalized. Still RBC is present. I could find only one other case report in Korean Journal of Transplantation. A live transplant. Creatinine jumped from 2.2 to 4.5 and POD5. Patient had anemia, thrombocytopenia, and LDH. The initial suspicion was TMA. Because of thrombocytopenia, biopsy was not done. But surgeon gave a clue that the patient had 2 small additional polar branches. Upper polar artery was missed. They did not anastomose. And when they did a renal angiogram, they found that the lower polar artery was thrombosed. The patient discharged with creatinine of 1 on the case. 1 year later, our patient had a hemoglobin was 11, creatinine was 1. Patient to date has urine RBCs, and patient is having a good quality of life. This was the flow, and Wales has already showed that flow, I think. RI and PI were normal, and now she's working as a work at home IT professional, happily living with her son and husband. It was a happy ending after all. Thank you.
Thank you, Shakti. Actually, we can take Dr. Vilas' case also. We'll have a discussion later on.
Yes.
Yeah.
Am I audible?
Yeah.
I'll share my slides.
Yeah, Dr. Vilas.
Visible?
Yeah. Make it as a full screen.
Yeah, I'll try to. Is it full screen now?
No, sir, just press
It
F5,
just-
sir.
F5.
Just press F5.
Okay. Now does it move?
Yeah. It's moving. Go ahead, sir.
Okay. After a very exciting slide presentation by Sakti, mine is a very hurried presentation made in 15 minutes. It will be lackluster, but probably it will set the similar message. Sakti, your presentation was very awesome. Okay. So we'll talk about the similar case scenario which Sakti had come up. And actually, that was an eye-opener when I had talked to him a few months ago regarding this case. So I work at Diamond Super Specialty Hospital, Kolhapur, and I'm the director of it. So a 24-year-old boy, 60 kg, primary disease was probably IgA nephropathy, and he was on dialysis for 9 months. See, he had severe hypertension and the anemia, which hardly responded to erythropoietin, and he was not on dialysis with me, but from a different district. Yes, his immune status was 1 haplotype match, only 3 out of 12 mismatches. He had never been transfused. CDC and flow cross matches were negative. Class 1 and class 2 PRA were negative by Luminex. Epstein-Barr virus, EBV, VZV, which I usually work up, were negative, and it was an intermediate TAC metabolizer. So yes, this was the DTP renogram of his donor, who was 49-year-old mother. If you look at the left kidney, it was 36. And if on the right side, it was 52. And this was the CT scan. Now, I don't know how clear it is, but this is the left kidney, and there is a very small artery which is originating just below the main renal artery, and it goes right up to the middle pole, parallel to this one. Probably this is a video. Is it playing?
Yeah.
Now, I think you can probably get a better view of that renal artery. It goes parallel to the main renal artery right up to the hilum. Probably, I don't know if it's visible to everyone. Okay, so the anatomy was the main renal artery, and there was a 1.5 millimeter or probably smaller accessory renal artery arising just from the aorta and was separating from the main renal artery by just maybe 2 millimeter, and it was running parallelly with the main renal artery and entering the mid-pole, right into the mid-pole. So looking at the anatomy, the surgeon decided that ideally it would be better to go with the right kidney. But again, the right kidney GFR was 52 and the left kidney GFR was 36. So for the donor's sake, the decision was taken that it's better to take the left kidney with an abnormal anatomy and he would prefer not to go with the laparoscopically, but with the open nephrectomy. So the surgery was on 14/12/24. It was a left open nephrectomy of the lower GFR kidney, that's the left one. It was noted that immediately after the nephrectomy, that there was a small rent in the smaller mid-pole artery, very small artery plus rent. While flushing, it was noted that fluid started coming out at the mid-pole. Our cardiovascular surgeon took a 18 gauge intracath, entered in and sutured that rent over that intracath and removed it and rechecked it. Probably there was no much leak from the mid-pole small 1.5 millimeter artery. Both were anastomosed to the external iliac artery next to each other. So the induction was thymoglobulin at 2.2 mg per kg body weight along with tacrolimus, steroids and MMF. Ischemia time was obviously prolonged to 66 minutes. But lucky for us that there was an immediate urine output on table as soon as when the anastomosis were opened, the ureter was anastomosed, everything checked. When they started the closure, it was noted, just a final check before closure, when we look at the kidney, the mid-pole, maybe about 30% or 20% of the mid-pole appeared bluish in discoloration. There's a alarm there, and immediately they rechecked again all the anastomosis, the bruise, etc. The anatomy of the small renal vessel was so complex that there are only two options: just forget it, tie it off, compromise it, because another anastomosis with a rent and at a 1 or 1.5 millimeter renal artery was technically very, very difficult. So there were two chances: just forget it or try something else. So something conservative was tried. A lot of warm saline was put into the renal fossa along with a couple of ampoules of papaverine, and just we waited for like 5-7 minutes, maybe probably 10 minutes. The urine output had slightly dropped, but it improved with all these measures, conservation measures. When we suctioned out all the normal saline and again looked at the kidney, there's a very small, maybe 5 or 10% area which was bluish, and most of the kidney had gained its the color back. We did an operative power Doppler, which showed pretty good flows at that point, even in the middle pole. So color improved. Intraoperatively, a 5,000 unit heparin was given with an idea that if there is any increase in the drain amount, we could reverse it by as needed. Post-operatively, as there was no increased drain, with some amount of risk, we gave 3,000 units heparin 12 hourly. The RFT was improving at 48 hours, though with all that edema, pain, everything. The Doppler was done, and the radiologist was quite sure that there is a good flow in the upper, middle, as well as the lower poles, and the power Doppler flows was good. Sakti, I'm sorry I couldn't get those images. I do have it, but I couldn't get time to upload all those images in my presentation for now. So the urine output in first 24 hours was 500 ml per hour. On the second and third day, around 300 ml. The creatinine was slightly slow to decrease, being a smaller kidney with a GFR of 36. An acceptable creatinine of 3.6 at 48 hours was noted. Day 4, baseline platelets were somewhere around 4 lakhs, and the platelets decreased to around 1.5 lakhs. Typical panic. When we have been listening to TMS in recent while a lot, probably in last 3 years, a lot of TMS have come up. So the moment our platelets start dropping, we start getting around, worrying around TMA a lot. Probably that's the worst case scenario to have. A post-transplant recurrence of atypical HUS, especially when we really don't know what was the primary disease of a relatively young male patient. So panic, probably TMA, DIC, along with sepsis, thymo, all those differential diagnoses which we had really already mentioned now. And we started working up for the same 4th and 5th day. D-dimer was normal, PTA, PTT was normal. We checked his cystocytes multiple times, it was normal. We were closely following up his procalcitonin and CRP in 12-hour-3, it was not so high, like less than 10. Blood cultures were sent along with urine cultures, which turned out to be normal in the following few days. So again, our Doppler was asked, not so easy to perform dressings, betadine contrast, multiple glows, compromised situation, patient complaining of pain when the radiologist tried to press the probe. But the radiologist was quite sure this time that there were relatively poor flows in the middle part of the mid pole of the kidney graft. So I remembered Shakti's case and called him back. Shakti, I am having a similar situation, probably not as bad as yours, but some drop in output, not so quickly decreasing creatinine and LDH in thousands, not like 2000 or something, but 1200, 1500. I think I should sit tight. So Shakti gave his inputs to me, and I sat tight on the in this situation. Did not biopsy, did not do too many things, did not go ahead with a CT angio, which I am always worried. I don't know how well or Shakti dares to do a CT angio in a post-transplant situation so easily. So, but RFTs were slow to improve, but they're definitely improving. Output was reasonably well maintained, 3 to 4 liters in the 24 hours. Also, I don't have an exciting table made by Shakti, but yes, if you could follow, his baseline creatinine hemoglobin was 1.7 and his platelet were in the range of 2.5 lakhs, which improved on day 1 post-operative to somewhat 3 lakhs, 3.5 lakhs. As his hemoglobin was quite borderline and his drain was high because of our heparin and all, we decided to give him PCV and kept his hemoglobin at around 9.4. Looking at the scenario, as usual, I have got a tendency nowadays to get a LDH done on day 2, 3, 4, and it was 412, not so bad. And his tacrolimus levels were like 13, not really way out of the range. So cystocytes were negative, DIC profile was negative, procalcitonin and CRP was not high, and we just started observing. At 48 hours, creatinine was 3.6, on the day 3, on day 4, 2.8, 2.6. But our LDH here was 1100, and this was like 12 or 1300 on day 4, 5, and 6. But having a previous update on renal ischemia and having a background of a very small artery which was rented prior to it was anastomosed, and again having a blue discoloration on table with some background information, we just sat on it, did not do much, and kept on monitoring the patient. So yes, this was day 26, that is day 12. The creatinine dropped to 1.7. His hemoglobin, which was around baseline 6.7 plus 1 PCV, but had dropped to 6.7, 6.8, had improved slowly to 8.7 on day 12. And probably we had tided over the crisis with some background information of the patient and some information from my colleague who had a similar experience with the case, and his platelet had improved to 2.68 lakhs, back to his baseline. So the last follow-up was 31st of December, creatinine 1.6, hemoglobin 9.6, LDH 3. In his 300s, and power Doppler, when the radiologist again looked at it and compared to his intra-op Doppler, post-op Doppler, it probably had reasonably improved flows in the mid-pole. So it had partially thrombosed, or I don't know, partially caused ischemia, or went into a spasm, giving rise to these problems, and then probably had some improved flows in that part of the kidney. So I think LDH is an indicator of tissue injury, ischemia, damage of any kind. It is, we all know LDH is present in multiple tissues, including liver, RBCs, muscles. So it's raised LDH, which may not particularly indicate renal damage, but damage to other potential organs which high LDH tissue content. And if you consider a graft dysfunction, ischemia, rejection, infections, TMA, sepsis, DIC causing some injury, even PTLD or PTLD doesn't stand in this context, but TMAs might cause this post-transplant LDH. So again, eye opener with some background information on what could be the differential diagnosis. Yeah, thanks for your patience.
Thank you, Dr. Shakti and Vilas. First of all, I'd like to congratulate both the presenters and Dr. Shakti for your wonderful presentation, and it was somewhat intriguing, and I must congratulate Dr. Vel Aravind and Dr. Shakti for this actually, and also my apologies because we are the donor hospital who gave the kidney to and we were very much sorry, and we were speculating how they are going to do that anastomosis and all. It was a really necessity innovates, that means it's a mother of innovations. So, and it was a really very good, actually. Many of the vascular surgeon would have fumbled in that thing, and you have made it a point, actually, creating artificial Carroll's patch and also extension venous graft. And he asked me, actually, when we retrieve that kidney, and we'll be telling about this scenario, and I was speaking to him, and he was asking for the graft. Just send me some of the artery and venous graft, so we could pack all the vessels and give to them, actually. So it was a nice presentation, and it's an eye-opener. That is, we learned a lot about that LDH in post-transplant. We'll be looking at that hard set, like LDH means TMA, like a all thing, and even microangiopathic hemolytic anemia. It's not common with the weight. We all think in terms of TMA, and all. And your perseverance of keeping the graft, and suddenly the graft opened up, and the Doppler and picking up the low flow in the middle artery, and the biopsies also was against your against your decision of keeping the graft, that is favoring your nephrectomy. But everything went well, and it was really a good experience to hear that presentation. And Dr. Vilas also, yes, came up with a similar presentations and a similar thing, and it was nice to hear both of you. And I look upon the panelists to give their opinions, actually. Dr. Santosh, to start with.
I think the approach that was presented, Shakti's presentation of the approach and evaluation, that is quite good for all our trainees who are listening, and for us to have a refresher. And of course, Vel sir's Jugaad was, I think it can't be called Jugaad. It is an adventure more than Jugaad. And hats off to you, sir. You've always been very impressive with all your surgical skills. I wish I had those skills. Fantastic, very impressive. And Vilas's presentation also is very nice. I think it's good that both the presentations came together, so we have a good
idea,
good round overview. Thank you. Enjoyed listening to everyone.
One comment: 90% of the surgeons and nephrologists would have discarded that Vel's kidney.
Yeah.
Nobody would have dared all those, dramatic efforts.
I think that one point about that cortical necrosis. Sometimes when we get cortical necrosis in the biopsy, it's very good to do a renogram or look at the surgical notes. It may be from a lower pole or upper pole that has got a small twig which has either been sacrificed or has thrombosed off. I think we should not get scared by that alone. We should look at the renogram and see, or look at the surgical notes again. Yeah.
Here, the Doppler is showing a very good flow that is unexplainable to the acute cortical necrosis. Diffuse cortical necrosis means the flow should not be there, actually.
Okay, sir. Raj, just a final comment.
Yeah. Your comments and acceptance speech also.
No, just 1 minute. So now, as final comment to Vilas, and if compromised kidney, the complex anatomy, I think you should think twice, Vilas, next time, and such kind of thing, because already you are compromising the compromised graft, right? One thing. Second thing, see, many of us, we don't reject nowadays all the multiple arteries. Now it's a challenge for us. Every organ is a very precious one, and we cannot deny anybody transplant just because we have the donor arteries are multiple. But thing is, when you do a multiple artery anastomosis, 3 ways you can justify that your anastomosis is good in a post-operative period. One is LDH, the eye opener. So you can keep doing once 3 or 4 arteries anastomosis, keep doing LDH. So probably 1 or 2 arteries must have gone. So that we can, or if LDH is normal, I think your anastomosis all were good. Second thing is you can go for a contrast ultrasound. Third one is angiogram. I think by three ways you can identify the success of a surgery. So this is the point I want to make here. And I do now started doing a lot of contrast ultrasound, where it clearly delineates your anatomy, right? So, and Doppler is a misleading. And if you go with the idea that middle pole you have thrombosed, you will report as a mid pole absence of flow. It is a purely subjective variation. I cannot trust those things. And only renal angio is the best way to go. So if somebody says that middle pole is absent or lower pole flow is absent, I think we have to take with a pinch of salt. I don't think it's correct. Thank you, Raj. Bye.
Thank you very much. Thank you. And with no other more questions, one chat box, there is one question. Why not trousering for the last patient instead of 2 anastomosis? Trousering for the last 2 patients. These arteries very nearby. That means double barreling. She is asking about double barreling.
Because and we tried all these things, it could not be approximated, because any double barreling there should be a relaxation. I mean, there should some redundant artery should be there to get approximated pantaloon. And if
I think they're asking about Vilas patient, sir.
Yeah. That's
case is a very short one. That I think probably I don't know, but it's a very difficult anatomy for that patient. It's very difficult. Actually, they succeeded somehow. It's very difficult. It's a close.
Very small actually.
Very small actually. What I would have done, that is different anastomosis, and what we have suggested to the vascular surgeon, we can take the small branch, we can make it a jump over the main one. We can anastomose the side to the main renal artery. That is the best way to go. Best way to go. You can easily make it, because if you watch the coronary people are doing, they're using coronary shunt. You can put in between, like, your catheter, they're putting there, over which they soon everything, right? So you can use the coronary shunt for 0.75 millimeter. All these are available now. You can put inside silicon, then you can do anastomosis and remove it. So what you could have done is, you can take the small branch, you can anastomose to the main hilar artery end to side.
No, well, that is okay with you, but my worry is they will also compromise the main renal artery. Forget the small.
This is the best way to go. Because you are taking a chance on left kidney, which is low GFR already. Very difficult, no?
Another 5-10% loss of GFR with that.
It's a hilar branch, it's a hilar. It supplies the pelvis of your ureter, so it's all very important.
Yes.
Very important, right?
Yeah. Okay, already we have exceeded the time, and with no other questions, I want to conclude this. Actually, we had a very interesting presentation to start with this new year. And when we learned about Fabry's, when to suspect Fabry's disease and when to treat and all, that was a good one. One thing we had to look upon whenever you have a tricky situation of LVH or cutaneous lesions or abdominal pain and all. And the presentation was very nice, actually. And second one, actually this is as Santosh had told, it is many eye opener for many trainees and nephrologists also. Seeing LDH, we learned from that we have to look for an LDH when you are doing the multiple arteries, and never trust on the Doppler, and never trust on biopsies alone, because it should be the conglomerate of all the diagnostic modalities to look for it. And the presentation was very interesting, and we learned about that ischemia is LDH. We should not be simply thinking about your TMA and all. And both the presenters, we congratulate and thank to the presenters who have presented very nicely, and the panelists who have come a long way and spending their busy time with us. And I must thank the delegates who have been constant support for us for all the past 3 years. And we encourage the institutes to come up with a presentation like this so that we can learn along with each other. And thank you, MQ team, for providing us a platform to give this meeting. And thank you one and all for the good, excellent session. And we hope to see you in the next month. Thank you one and all for joining us. Thank you.
Thank you, everyone. Good night.
Thank you.
Thank you. Good night. Thank you.
Thank you. Thank you.
Thank you.